Good day. I'm Anna Nolte, and we're still busy with HIV and PMTCT, and we'll do lesson 3, which is focusing on the breastfeeding and the newborn aspects of HIV and PMTCT. Now, we ended the last lesson with care to the baby, and I said we will do it in much more detail in this lesson. So we start here with all HIV-exposed infants should receive at birth a PCR test to identify whether the HIV virus has been transmitted to them in utero. And these HIV-exposed infants should then receive a minimum of 6 weeks post-exposure prophylaxis with nevirapine. And then we also need to identify the high-risk infants, the infants where the possibility of vertical transmission was very big, and they are babies where the viral load of the mother was bigger than 1,000 cc per milliliters, or where the mother's viral load hasn't been done during the last 12 weeks. So we actually don't know what the viral load of the mother is. And these babies should be provided with high-risk prophylaxis until the results of the delivery viral load of the mother is available, and also when the results of the PCR, the delivery PCR of the baby is available. And then the baby can be classified into a high risk or a low risk, and the prophylaxis should be adjusted then accordingly, according to that. Now, we have said in the previous lessons, and this is just a quick revision again, that the baby might get infected. So in other words, transmission from the mother to the baby might happen during pregnancy when the HIV crossed the placenta. We've said if the viral load of the mother is so high that it crosses over the placenta, and then the baby will be infected, or if the placenta or the baby has been injured in utero for some or other reason. And then during labor, when the infant becomes infected because he has to pass through the cervical secretions and get into contact with maternal blood. Or after delivery, when the infant may become infected with HIV present in the breast milk, and that's what we will talk largely. Now, the big question that arises now is whether mothers with HIV infection should give breastfeeding or not. And the question that we ask here is if the mother has an undetectable viral load, whether she can still transmit the virus through her breast milk to the baby. Now, it's a very difficult question to answer because there's not a lot of research being done. The research that's been done is limited about the viral load, regarding the viral load and breastfeeding. There is, however, some evidence that in the case of undetectable viral loads, that there is some protection from the HIV virus transmission. We've said that most of the transmission happens when the viral load is very high. But there were some cases where the HIV had been transmitted to the baby, even when there was undetectable viral loads. So the big question arises, should the mother breastfeed or should she not breastfeed? And we will come to some statistics a little bit later on again. I think one has to weigh the advantages of breastfeeding against the possibility that the baby might get infected. We have seen in lesson 1 also that when mothers are on ARV treatment, that the possibility of transmission also becomes less, but there's still a possibility that the HIV virus can be transmitted. So the information that mothers should get is, and should receive, is that there's always, although it might be very small, a possibility that the HIV virus might be transmitted through breast milk. Now, the WHO recommends that in the low and the middle income countries, that the risk of bottle feeding is much higher, and the risk of babies dying because of undernourishment and diarrhea, etc., because of bottle feeding is much higher than the possibility of the fetus, of the baby, getting HIV infected through breast milk. So in the low and middle income countries, it's considered that breastfeeding is the best type of feeding instead of bottle feeding under bad circumstances. Now, I'm saying here that disclosure plays a very big role in the decision making, and that's very important because, first of all, if the mother has disclosed the HIV status to you, it's so much easier to talk to the mother and to give her all this information for her to make an informed decision. On the other hand, disclosure also plays a role in the sense that mothers are being almost forced to give breastfeeding because the family might need to know why she's not breastfeeding. She needs to explain to them why she's rather bottle feeding than breastfeeding. And the same when we come to, for example, pasteurization of breast milk and things like that. They have to explain why they are doing all these additional things instead of giving breastfeeding. So the fact that they are too scared to disclose their HIV status might force them to decide on a specific feeding. The question arises, how is the HIV virus transmitted in breast milk? The virus as such is present in breast milk, and it's also present in the white cells and the leukocytes that's been present in breast milk. And that's why even with a non-detectable viral load, the HIV virus can still be transmitted to the baby. So the baby can be infected with HIV viruses anytime that he's receiving breast milk, being breastfed. We've also said that if the mother gets newly infected while she's breastfeeding or continuous exposure to the HIV virus while she's breastfeeding and a viral load becomes much bigger, again, the transmission of the HIV virus becomes quite big. So I think the instability, if I can call it like that, of how much HIV viruses the baby is being exposed varies through breastfeeding, and that makes it a little bit more unpredictable and better for the baby to rather not receive breastfeeding than to receive breastfeeding. Even if the baby received expressed breast milk, there's still HIV viruses in the breast milk, and he can still receive it through the breast milk, except if the breast milk is being pasteurized, as we will see later. Just a little bit more about transmission and whether the mother should give breastfeeding or not. And I think this is not also information for the mother in order for her to make an informed decision, but I think to a very large extent also for all of us to help us to give the mothers the right information to make an informed decision. Now, we have said previously in the first lesson that the transmission through breastfeeding is very low if the mother receives the correct ARVs and if she adheres to the correct ARVs. But there is, as we've said, still a risk. And when the mother is on ARVs, the viral load, and there's a non-detectable viral load, there's still a 0.3% possibility that the HIV virus can be transmitted through breast milk. Now, factors that increase the risk of HIV transmission through breastfeeding, and we have talked about many of them previously. I'm just going to emphasize them. A mother with a very high viral load. And that she doesn't only need to start with a very high viral load. As we've seen now several times, the viral load can be increased because of certain behaviors, getting newly infected, getting exposed continuously, etc. Also, mothers with a very low CD4 count, because they are usually, the mothers with a high viral load and the low CD4 count are usually those ones that's most affected by HIV disease, and they are often the ones that's not adhering to the ARV treatment. Other HIV-related illnesses, that's now the opportunistic infections, mothers with tuberculosis, etc., obviously will be, there's the increased risk for transmission. We have talked about the fact that sexually transmitted diseases also increase the possibility HIV transmission. The mothers who were newly affected, the mothers who got HIV during pregnancy and even now during breastfeeding, have a bigger risk of passing the virus on to the baby, because, as we've said, the viral load is so much higher now. Unprotected sexual intercourse, as we've said several times, that means she's exposed to the high HIV virus several times, and that makes the viral load also much more higher, and when she's not adhering to the ARVs. Now, there are also some other very important aspects regarding breastfeeding and HIV infection, and that is that if the mother does decide to breastfeed, it's extremely important that she should give exclusive breastfeeding for at least 6 months. Now, exclusive breastfeeding means exclusive breastfeeding. It means she gives nothing else but breast milk, not even water, because what happens is when, in the case of a mixed feeding, and that, as I've said, even includes water. So the moment that the mother starts with adding other milk formulas, adding bottle feeds, or even starting to add solids too early, what happens is that it increases the risk of HIV infection, because it changes the bowel mucosa of the mucosa of the gut, and it causes a mild bowel inflammation, which make that the HIV virus can very easily get from through the bowel, through the gut, into the baby's bloodstream, and then the baby has been HIV infected. The other factors that also increase the risk of HIV transmission through breast milk are mostly breastfeeding, the breast milk related. Now, we have talked about these first two several times, so I'm sure you're familiar with them now. If she's becoming infected while she's breastfeeding, or when she's been exposed to the virus several times because of unprotected sexual intercourse. But then other factors play a very important role, like, for example, cracked or bleeding nipples, because that it speaks for itself. The moment that there is blood that the baby might get in through the breast milk, obviously it's just been exposed to much more HIV viruses through the blood. And also when the mother has mastitis and breast abscesses, because very often there's also a little bit of blood in the breast milk, but there's also a lot of leukocytes because of the infection in the breast milk, that also increases the transmission of the HIV virus. The same with mothers with engorged breasts, also because there is, to a certain extent, inflammation and duct damage, the milk ducts being damaged, there's an increased number of white cells, and again that increases the HIV infection to the baby. Also, when the baby is having sores in his mouth, because that breaks in the mucosa or in the skin, and that causes the entrance place for the HIV virus and can get very easily into his bloodstream. And this is specifically true for babies who have thrush, because that just increases the risk of HIV infection. And then also when the baby is having diarrhea and vomiting, as we've said, the changes in the mucosa of the gut might just make it much easier for the HIV virus to go through. Now, I have talked previously about pasteurization, that one can pasteurize the breast milk. So if the mother is really very keen to breastfeed her baby so that he can have all the advantages of breastfeeding, one can always teach her to pasteurize the milk. The reason why home pasteurization of breast milk is not very popular is because it's quite labor intensive. And then also, as we've said previously, the mother has to disclose her HIV status if she wants to do that, because obviously the family or the partner might need to know why she's doing this to the milk. So what usually happens is one can boil 450 ml water in a pot. It's not the quantity is not shouldn't be exactly 450, but one can boil water in a pot, remove the pot from the heat, and then place the breast milk in a glass jar, about 50 to 150 ml expressed milk, and then allow it to stand for 15 minutes. Or one can just use boiled water from a kettle, put it in a some or other bowl holder, and put the jar of milk into it, and also let it stand for 15 minutes. So what we are basically doing is we have boiling water, we put the expressed milk in a glass jar in the boiling water and leave it there for 15 minutes. And this is also specifically a very useful procedure when these preterm infants that's been in hospital and the mother wants to give expressed milk to the preterm baby to give him the optimum value of being breastfed. Now, the other, I've said this is quite labor intensive, except for this whole procedure to pasteurize the milk. Also, the milk has to be expressed first. So the mother is quite busy expressing milk and then also pasteurizing it. But when mothers are really motivated to give breastfeeding, this is one of the ways that she can overcome the possibility that the baby gets being infected by the virus. There's also commercial pasteurizers available, but they are quite expensive. Okay, then also very important, how should these infants born to HIV positive mothers be followed up? Very important that they should come to the mother and baby clinic for the more or less during the first 6 weeks, but then definitely at 6 weeks as well, because they need to get another PCR test, as we've said previously, at 6 weeks after the delivery. In the meanwhile, these mothers should be encouraged to give their babies the prophylactic nevirapine, as we've said, on a daily doses. And then the PCR should also be done then at 10 weeks after delivery of all HIV-exposed infants. And if the test is positive, it means that the infant has been infected with HIV, the virus. And one wouldn't be able to know whether it's been infected because of during labor, antenatal, or breast milk, if the mother is giving breastfeeding. If the baby is negative, then and the mother is not breastfeeding, the baby will stay negative. But if the baby is negative and the mother still breastfeeds the baby, there's still a possibility that he can get infected with HIV. So he needs to be tested on a regular basis to make sure that he stays negative. So it should then be repeated in 6 weeks again to see, as long as she is breastfeeding him, to see whether he gets positive because of the breast milk or not. And then this is, I think, you are all very familiar with this. This is all very well known on how the precautions to prevent HIV infection when you are caring for HIV positive patients. I think, especially in private hospitals, we're not 100% sure whether patients are HIV positive or not, because all patients are not disclosing their HIV status. All patients should be regarded as potentially HIV positive patients. Now, I think, as I've said several times, it's just much easier if we know that the patient is HIV positive, because we can give and talk to these mothers just much more freely and give them the necessary information that they need. But if we don't know what they are, all mothers should be treated as potentially HIV positive patients. And then all the detail about washing your hands with disinfectant, washing your hands with soap and water if they became contaminated with blood, to use gloves whenever you handle any body fluids, to wear a mask, specifically a plastic mask, which we will come to just now, for in case fluids may splash into your mouth or into your face. To wear protective glasses, as we've said, specifically during labor when the membranes rupture and the liquid can splash into your face, and to wear a plastic apron for the same reason. We all know, I'm sure you all know how to deal with soiled linen and what to do with them. And obviously that you need to wear gloves when you are handling soiled linen. And this specifically, obviously, after delivery when the linen is soiled with blood and glycol. And then also, I'm sure you all know how to handle sharps and needles and lancets, etc. And that brings us to the end of this HIV PMTCT series. I hope, really hope that I've just reminded you of a lot of things that you might have forgotten and that maybe you have learned some new things as well. Complete your quizzes and then you are done with this.